So now let's talk about diseases. Any disease that affects the ability to not clot properly, we call it a coagulopathy. All right? Coagul is clotting, opathy is disease. So here's the first one, DIC, disseminated intravascular coagulation. Who here has heard of this one? Okay, a couple people. Good. Okay? This is fatal if not treated, and it depends on the situation. It may still become fatal. It's a severe clotting disease, and what happens is we don't understand the mechanism, what started it all. We know risk factors, but we don't know why it actually does it. I'll show you the risk factors in a moment. But it starts making multiple small thrombi, meaning small clots are being developed. And they start making more and more and more of these clots. The platelets are being used up, and all the clotting factors are starting to get used up. Until you have no more to use. Now they're just all clots. So it looks like it's clotting too much. That's not the bad part. Well, that's the start of the bad part. But the bad part is that this is all happening without the broken blood vessel. But the bad part is that we have this consumption coagulopathy. All these clotting factors and platelets and fibrin are all being used. So now when you do have a hemorrhage, you have a big problem. So those thrombi use up all the clotting factors, even the platelets, all the fibrinogens, all being used. Now your body can make more, but that takes days for that to happen. Well, what if when you now have something you need to make a clot, you can't? So now when abnormal bleeding occurs, and I'll show you those conditions, no coagulation occurs. These people start bleeding all over the place. Massive bleeding that you can't stop. So you get the spontaneous bleeding from the nose, from the mouth, from the IV sticks. They just keep on happening. So the risk factors or the diseases that usually causes, because DIC is never a primary disease. It's not, it's from something else. It's secondary to something else. It's not primary. So it could be due to obstetrical complications. A woman who just delivered a baby, the placenta comes out, and now hemorrhage is happening. So now, for some reason, it's making all these clots, but now it uses up all the clotting factors and platelets, so now the bleeding continues and continues and continues. It can't wait for your body to make these clotting. The liver can't make them. God bless you. It could also happen in pregnancy, severe hypertension, if the placenta separates prematurely, even a dead fetus that's in there, spontaneous abortion, a miscarriage. Most times it'll come out, sometimes it stays in there. Depends on how many weeks it is and if the woman wants to go for a D&C, but we're always trying to be, we want to get it, if it's not out in a couple weeks, we need to go in and remove it if it's still there. Sometimes it can get absorbed. But if it's still there for a few more weeks, our worry is that it may use all the clot, because now in there it's going to start clotting, and then it could go into DIC. It's rare, but why worry about that? Okay? Infections, sepsis, malaria, this can also cause DIC. Certain cancers can cause DIC. Massive tissue trauma, burns, all right? And other weird things like snake bites and heat stroke and so forth. But it's never, DIC is never a primary disease. It's because something occurred. Why that causes the DIC, we're not too sure. But we know these things can cause that. And the treatment is, you have to just load them up with fibrinogen because we can't wait for their bodies to make the fibrinogen, or we have to give platelet transfusions. And hopefully that'll work. The prognosis, well, it depends. It depends on what the cause is. But usually, it's a poor prognosis if the DIC is really severe. All right, so that's what DIC is. Questions? Okay, a thrombus. A thrombus is a clot that develops and persists in an unbroken vessel, blood vessel, BD blood vessel. So you have a clot that occurs. Now, normally you're supposed to have a clot if there's a broken blood vessel. You cut the blood vessel, sure, a clot makes sense. But when it doesn't, we're looking at this positive feedback, right? So thrombi can block circulation. It starts building up, right? You start having this blood vessel over here, and it's not broken, the blood vessel. And all of a sudden, platelets start forming over here, and it starts sticking and forming a blood clot. Well, the blood flow, I'm going to have eddies start forming over here, but it can eventually block this whole blood flow, right? That's what's going to happen here. If that builds up so much, then the tissue over here is going to start dying and cause necrosis. No oxygen to get on that side. All right? Thrombophlebitis is a fancy word when this clot is attached to this blood vessel. Well, this blood vessel gets irritated and starts getting inflamed because this clot is actually irritating it. So that's what thrombophlebitis is that the walls of the veins get inflamed and get very painful because the clot is there. Our concern is that if it happens in your veins of your legs, it's called a deep vein thrombosis, more likely in the popliteal vein or the femoral vein, and that's what happens with this. You get a clot that goes in the leg, and we see a lot of people over here, like if you're taking a plane flight for 5 hours and not wanting to walk, or you're taking a car trip and you're not deciding, you want to travel the car trip 8 hours without getting out for a walk. If you're sitting there, the blood is going to go to your legs and start pooling in your legs, and it's going to start coagulating. Then when you get up, that blood clot can break off and it can shoot right into your lungs. Now, that's called an embolus. So you have this thrombus that breaks off and embolizes into your lungs. So my question is, why your lungs? Not why does that cause problems, but why does the first place it goes is your lungs? How does it go from here to your lungs? And why doesn't it cause a problem here, or here, or here? Why is it the lungs it goes to? I didn't hear you. Go ahead. Bingo. She hit it right on the nose. What it is if this is your leg, let me do it this way. So this is a vein in your leg, and the blood clot is here. Okay? Your heart is up here. Now, as these blood vessels, and this is in your leg, as it goes into your vena cava, is the vena cava a bigger diameter or a smaller diameter than the veins in your legs? Bigger. So what's going to happen here is, I'm going to exaggerate so you can see it, but as it goes into your vena cava, it'll do this. Right? Not that big, but you get the picture. Thin veins here, thicker veins going up. So if this breaks off, it's not going to occlude anything in here. If this gets broken off, it could easily embolize here. Look at it. It's not going to block anything. Your chambers in your heart are still big. So even if they go in the right atrium and the right ventricle, it's not going to get lodged in there either. But now, from the right ventricle, what organ does it go to? The lungs. So now you're going to have the pulmonary arteries, still pretty big, going into a lung here. But as it's pretty big, does it get smaller going into the lung, or does it get bigger? Smaller. So it's going to go into your lung going smaller, and that's where it's going to get lodged. That's the first place it's going to hit a small vessel. So that's why you hit it right on the nose. That's where you're going to hit it. It's not because it's most dangerous there. It's because that's the most obvious place it's going to hit first. And now, when blood needs to go here, if this is a blood vessel that's going to take care of this whole area of the lung, well, now you can't get blood in that area. If you can't get blood in that area, you're not going to get full efficiency of breathing. If that blood clot is huge, it could shut down 95% of his lung. This is not good. This breaks off, and I drew it kind of slow for you. It happens quite rapidly. And that's a classic situation. It's like you just get off of a plane that was like for 8 hours, and all of a sudden you can't breathe. A young person, that's what you're thinking. These little scenarios that are little pearls on NCLEX and stuff. Person coming off of a plane that's, let's say, 14 years old, just traveled from here to India, and now is complaining of shortness of breath. What's the most likely diagnosis? Well, geez, they didn't give that much information. Right. From that information, what are you thinking? That's what you got to put all together here. Okay? Questions on that? All right? So that's what that is. All right? Risk factors from other diseases. Thrombus. Being able to clot inappropriately. Okay? These can cause emboli and recurrent spontaneous abortions. Recurrent miscarriages, in other words. Having this, and these are genetic things that just get passed down. We have something called Lupus Anticoagulant, or LAC. It's also referred to as antiphospholipid antibody. This is autoantibodies, and about 10% of lupus patients has this. Now, this is kind of a misnomer because most patients who have this lupus anticoagulant have nothing to do with lupus. They don't have lupus at all. So it's kind of a misleading thing because you think that, well, geez, it's going to be, no, only 10% of people with lupus have this. So lupus can cause clots, okay? Especially if you have this. Most people else don't have this, and this promotes venous thrombosis, just having this, okay? We also have another one that's a little bit more prominent. It's called factor V Leiden, okay? That D is the 5. Factor V Leiden. It's an autosomal recessive disease passed down from generation to generation, okay? It produces abnormal clotting factor V. It makes the clotting factors work too much that it produces more clots. What makes this even worse is if you have factor V Leiden and you're a smoker, there's even an increased risk more of producing thrombi. Or if you have, what do you think OCP is? Oral contraceptive pill. All right? So birth control pill. You'll see that quite often in the medical realm. Oral contraceptive pill. All right? So even women, because it's estrogen, high doses of estrogen will also cause thrombosis. Pregnancy can cause thrombosis. There's high levels of estrogen. All right? And this produces or promotes venous thrombosis. Okay? So that's factor V. You know how Julius Caesar orders 5 beers? He just went, yeah. Think about it. All right. All right, so pulmonary embolism, we kind of talked about already. Blockage of one or more pulmonary artery. It's life-threatening. This is not something you just like, just sleep on it. No, you take them into the hospital, and we've got to start treating them. The blood clot starts from the deep vein, and these are different things. Prolonged bed rest, someone in bed for a long amount of time. You're not moving the leg. There's a greater chance there's going to be blood pooling there. You get up or move your leg, it can shoot a clot going right into your lungs. Surgery. You're on the bed or anesthesia for more than an hour. We start doing things. You need to make sure that they have compression stockings or TED stockings on their legs. Those are like compression stockings so that if you're going to be moving, it actually presses so much that it'll make sure that the blood doesn't stay into your legs. It kind of milks the blood forward. So we want to do that. Long plain play, obesity will do that. Certain genetic diseases that I just mentioned. Cancers will do this too. Excessive estrogen, as I just showed you, for oral contraception, pregnancy. Okay. Fat globule. Yeah, you break a long bone. You break your arm. Inside your long bone is loaded with yellow fat or yellow bone marrow. Well, if you break a bone, that little droplet of fat can go into your bloodstream, and that can cause, that's an embolus. So I want you to try and get out of the idea that thrombi and emboli are only blood related. No. I'll show you. I have a little mnemonic to help you in a couple slides here. But you should know other things can cause that. There's another pointer for you. Here's someone that just broke his, 14-year-old boy who was playing baseball. He fell down and he broke his leg. Now he has shortness of breath. And you're probably thinking, not you, but let's say someone's probably thinking, well, geez, it's not because he was on a long plane flight, so, no, why shortness of breath? Maybe asthma? No, he broke his arm. These are little pearls. They see that. If you see that, that's what I mean. It's test-taking strategies. You start seeing certain things written in the question. You could almost guess, I know the choices, and I know which one I'm going to pick. You got to put this stuff together. Okay? So this is the traveling of the embolus that I kind of showed you, and there's a nice animation of the whole thing. Okay? So that's where the embolus happens. Here's one. It's pretty big. It's actually hitting this, so this part of the lung is not going to function. This part is not going to function. It could be pretty big if it shoots up that far. All right? Keep in mind, that's a big distance. You could have a long one over here. The first place it's going to hit is going to be like in here. All right? So risk factors, what is this? Air pressure. And the other class they were saying, well, he's on the phone. No, the phone has nothing to do with it. Right? Oral contraceptive pill, obesity, surgery, and pregnancy. These are major things. So my women who are patients who just had a C-section, who's obese, they're right there. They just had a C-section, and they're obese. So they're still pregnant. You're not pregnant anymore after 6 weeks of delivery. So you still have all the hormones. So you have this and this. She's obese. She just had surgery, and now she's bedridden. I had a couple people who had PE. They're a setup for that. Okay? That's why we want to get them walking as early as possible. Not because we want to push you out of the hospital, but we don't want you to have complications, morbidity, let alone mortality. All right? There's my little mnemonic. All right? F.A.T.B.A.T. Fat, right? So you have the fat that could be from fractures from long bones. Air. Any divers here? Scuba divers? All right. Basically, this is nitrogen bubbles. Normally what happens is when you go deeper, the atmosphere, and we'll talk about the bends later on when we get into respiratory, but what happens here is that as you get deeper and deeper in the water, the air or the gas itself gets more compressed. So it starts getting dissolved easier into your bloodstream. So nitrogen bubbles will actually go into your bloodstream, and it's fine because they're so small. But if you go up too fast, it doesn't give enough time for the nitrogen bubbles to leave the bloodstream out into the lungs so you can breathe it out. So now you have these air bubbles that are going to be stuck in there, and those could get stuck into your lungs. A thrombus, of course, bacteria from different areas. If you get, let's say, a tooth that gets removed or whatever, and now you've got bacteria that's in your mouth, and it goes into the bloodstream, and you just open up a blood vessel, sure, that could float all over, and if you have a bunch of bacteria that coalesce together, that can cause that, right? Amniotic. After you deliver a baby, now all of a sudden a woman can't breathe. First thing you're thinking about was, what I'm thinking about, is that, A, it could be because the placenta, some of the amniotic fluid might have gotten into the bloodstream of the mother, and now it's going right into the lung. Okay? And yes, METs, when you have enough cancer cells that agglutinate together, or come together, that can also be big enough where it could go into the lungs. So please, don't think that clots are just blood. It can be other things. All right? It's you trying to put this stuff together when you do your NCLEX or my exams, and you start seeing a woman who just had delivered a baby is not breathing properly, think an emboli. Maybe it's going to the lungs. Okay? Prevention of undesirable clots, aspirin. All right, aspirin, this is the big one. We've been talking about aspirin. Aspirin is a prostaglandin inhibitor. Prostaglandins, as you've seen, do a bunch of different things. So aspirin is going to inhibit the prostaglandins, let alone what it's going to do here is it's going to cause the platelets to not stick together. That's why a 50-year-old is on a baby aspirin a day. It's going to decrease clots by making the platelets not stick together. You don't want to have a clot going into your coronary artery, and you're not going to pump the blood, right? So that's where that comes in. We have heparin, all right, and we also have warfarin. Warfarin and Coumadin, same thing, but this usually hits the intrinsic factor, intrinsic pathway, and this is the extrinsic pathway. This competes with vitamin K. That's how this one works, the warfarin. You might have warfarin or Coumadin in the house, not because of the medication, but it's underneath the sink. What else is warfarin used for? What did you say? Rat poison. Yeah, rat poison. So we could have, let's say, a kid going underneath the sink, and he takes some of the rat poison. That's how rat poison works. They bleed internally. That's how they die. So now they have a child that's going to take some of this rat poison. Now that's what they're worried about. So let me ask you this. If a child takes rat poison or warfarin, or the reagent or the antidote that the ER is going to give that child? So it counteracts the effect. Yeah, vitamin K. Right? Because warfarin competes with vitamin K. So now we're going to put a whole bolus of vitamin K in the kid. So hopefully it'll knock off the effect of the warfarin. Hopefully. Before it did anything. Right? That's what I'm saying. When you get into pharmacology, understand the mechanisms. Don't do it for the test. Do it for, well, not even the NCLEX, for the future. Okay? All right. So bleeding disorders, make this really quick. Thrombocytopenia. This basically means low platelets. You're going to see this often, this suffix here. Penia. Penia means a decreased amount. Cytosis means an increased amount. So you have thrombocytopenia is a decrease of platelets. If I had thrombocytosis, then that's an increase of platelets. But keep in mind, penia and cytosis, those suffixes, you will see for the rest of your career. But you're going to see it often. Neutropenia, right? The neutrophils are very low. So you're going to see these quite often. So just get in the habit of seeing that, okay? So platelets are less than 150,000. Normally, it's between 400,000 to 150,000. If it drops down to this, think something's going on, okay? It's caused by suppression or destruction of the bone marrow. Whatever that is. It could be malignancy, it could be radiation. Certain medications can cause that, destroying that bone marrow. And what we have is idiopathic thrombocytopenia purpura. Idiopathic thrombocytopenia purpura, or ITP for short. This is more common than what you expect. You see it a lot in children. Not a lot, but that's more common in children. It's an autoimmune disease that attacks the platelets. Most of the time, this kind of goes away. You don't have it forever. It's a temporary thing. And what you end up getting is these little petechiae. You get these little hemorrhages. The petechiae kind of looks like little dots. I'll show you what that looks like in a moment. Or you have bigger dots. Well, they're not really dots. They look like bruises, and they're called ecchymoses. And then if they're really big, then we just call them hemorrhages. So we just kind of get bigger and bigger and bigger. And that's what petechiae look like, these little dots. All right? And ecchymoses is these big bruises. You just bleed all the time on there. You see, you're bruised quite easily. This is the kind of stuff you see, let's say, in a child of, let's say, 5, 6 years old. You take them to your daycare and you see that you have all these here, and the first thing that people are thinking is abuse, whether at home or happening in their, and that you definitely have to rule that out. I'm not saying don't rule it out, but you also have to see if there's any kind of diseases that the child may have to be causing this. That could ruin a father's or a mother's life, you know what I'm saying? If you get accused of this and it turns out to be just ITP, which usually is self-limiting. You just got to be careful with that and see how long it lasts. But that's what I'm saying, you just have to be careful with that. Liver disease, like I said before, if you have liver disease, You can't make clotting factors, so you're not going to clot. Remember, vitamin K is needed for clotting factors 2, 7, 9, and 10. If you don't even have vitamin K, that will also cause some sort of clotting issues. All right, you'll just bleed. Okay? Hemophilias, remember how we talked about clotting factors? Hemophilias is that you're missing certain clotting factors. For instance, hemophilia A, all these are X-linked. So in X-linked diseases, is it more often men have it, more often females have it, or is it equal? Men, right? Because, let me just show you really quick about this. Men are XY, women are XX. So if it's an X-link and it falls on the disease, it falls as a disease that falls on the X. On a woman, if this is where the disease is, well, you got another X that's completely normal. So therefore, she shows us she's normal. On a male, if the X gets ruined, there's no other X. So he's going to show the disease. Does that make sense? Right? That's basically how you see. The only way she can get it, it's very rare, is that she's got to get a gene that has this from mom and from dad. That's hard to see. You know, two hemophilia, mom and dad, they usually want to like adopt this because they don't want to have their children go through it. Not all the time, but it's difficult for that for us to see that. So hemophilia, most common type, this is when you have factor VIII missing. And they're just going to have to get more factor VIII in them for the rest of their lives. Okay? Hemophilia B is the next more common one. That's when factor IX. Now this one is kind of a weird thing, but each one of these factors have different names to them. Like this one, factor IX, is known as Christmas factor. Not because of the holiday, but the person who had this hemophilia, his last name was Christmas. So it's just named, it's one of those eponyms. So believe it or not, having hemophilia B, it's also known as Christmas disease. Go figure. All right? So that's what that is. All right? And what causes clotting? These are just a list of different things. We kind of mentioned some of these. And what causes bleeding? These are some over here. Okay? This other part is kind of wrapping things up, kind of closing the circuit of this. So there's just a few things over here that we talked about and what you should understand about. Not much. A bone marrow biopsy. So they need to see what's going on inside the bone marrow, whether it's leukemia or we need to see how much ferritin is in there. So we got to do certain things like for iron and stuff. What they do is they take a sample using a needle and they go in the posterior iliac crest over here, and it's pain as hell. Putting a needle right in your bone to get some biopsy. So it's also the same site that they'll do for bone marrow transplant also. There's blood transfusions, right? So whole blood. There's also, remember how we talked about this thing here, this is your centrifuge. So you go, this is your red blood cells. This is going to be your platelets and white blood cells, and then up here it's going to be your plasma. Well, what happens here is that when you give blood, you're giving whole blood. Okay? So, you know, it's not going to be all separated like this, it's going to be red. But then in a blood bank, what they do is they look up on their shelves and they say, you know what, we're running low on whole blood. So the blood that you're going to be giving, they put in a bag and they put it right up there. But then they realize, you know what, we're running low on red blood cells. So they just spin this whole thing, and then they can just take out just the red blood cells. And that's called, even though it's red blood cells, we call it packed red blood cells. And that's, see, when they give blood to someone, they're only going to give you the stuff that you're missing. I mean, if you cut off your hand and all blood is coming out, you're losing everything. But if you're just missing red blood cells because your erythropoietin is not working, or you're low on iron, whatever, if you're not making red blood cells, but you're making platelets and your plasma, they're not going to give you this stuff. They only want to give you the stuff that you need. And that's what happens. You might just get the plasma. All right? The plasma containing clotting factors for hemophiliacs. So you might just get that part. So they're only going to give you what you really need, and they can use the other stuff for other people. Okay? Also with a bone marrow transplant, and remember how I explained what that was, a bone marrow transplant, for some reason, your bone marrow is making leukemic cells. So what they want to do is destroy your bone marrow. They're going to put you in aplastic anemia. They're going to radiate and destroy with poisons all your bone marrow because it's making cancer cells. So let's destroy all this. So they're kind of doing a iatrogenic aplastic anemia. Then you've got nothing there, and that's why they're going to work fast. You get a donor who's the closest match and puts in some of his bone marrow and puts it into your, well, they infuse it into your blood. And I'll show you where that comes in, okay? And hopefully it goes into your bone marrow, and they're good cells, and hopefully they're going to divide into cells that will continue to do good cells. That's basically what a bone marrow transplant is, okay? And then you got this plasmapheresis. This is where whole blood is centrifuged, like this. It's spinning around, and it separates everything. And then plasma is removed, and it's pooled with other donor plasma. And the plasma can then be transferred to a recipient who needs, let's say, certain things. If they just need plasma, if they need albumin, the clotting factors. So it's kind of a mixture between the donors and the recipient's plasma, and they'll do something like that. This is just a picture of just showing a bone marrow transplant. So they're going to take the cells from a donor over here and then be able to mix it with some anti-clotting agent into a bag to put it into the person's bloodstream. Eventually, it's going to go into the bone marrow and hopefully make those cells grow into the bone marrow. Then I just have a list of different medications over here that we kind of talked about. I'm not going to ask you so much about this, but we talked about, if someone has like renal disease or kidney disease, then they're going to need some sort of synthetic erythropoietin, something called Procreate. I'm not going to ask you about this, but I may ask you, like, how would you treat someone who's got renal disease? You don't have to say Procreate. You can just say, do you give erythropoietin? Do you give, because it helps you understand the pathophysiology. And of course, supplemental nutrients like iron, folic acid, and vitamin B12. Vitamin K was used for what? Vitamin K, what is that used for? Iron, folate, and vitamin B12 is used for, that's for iron, or not for make a red blood cell. But what's vitamin K used for? No. It's still about blood. It's needed for certain clotting factors. So it's needed for that. Specifically, clotting factors 2, 7, 9, and 10. They're all made in the liver, but the liver needs vitamin K to make 2, 7, 9, and 10. Yeah. Okay? So then we do the case studies, and you do those on your own.